Thank you for the warm welcome. I'm very happy, to be virtually, there. I've heard a lot about CFRI over the years, and my patients have benefited from many of your programs over the years. So it's sad that I'm not there, but we can see the positive, sides of not having to travel across the country for a weekend. This is, my disclosures. This is some of the objectives that I would like, people to get out of, listening to this talk. And this is an outline. So we're gonna kind of go over different types of issues and cancer that happen in cystic fibrosis. Talk a little bit about why this is important, how cancer prevalence, what the cancer prevalence is in cystic fibrosis before and after a lung transplant, and then focus on specific, types of cancers like GI, skin, and lymphoma, which are probably the more common, ones that we talk about. So this is a boring slide, but just to remind everybody, we have seen tremendous survival changes in cystic fibrosis over the last 30 years or so. So there is a big difference on how old the population is now and how it was 30 years ago or so. And even if you go 30 years before that, there were not even adult patients at the time. The slide shows the same thing. A lot of my colleagues in adult cystic fibrosis, they see a huge, increase in the number of patients that they treat. And you can see over the years, the adults now outnumber the kids. And also, a lot of the care happens in adult centers because the pediatricians and the parents and patients with CF has done such a good job that kids tend to be healthy, which is a great thing. This is a slide that I want to stay for a few minutes, longer. And this is the age distribution of patients with CF in 2008 and 2018. The reason I chose 8 is the easiest one where there's an online patient registry, report, so you can, grab the slide. So if you notice, this area of patients with CF down in the 30 and 40 years in 2008 is much thinner compared, to now. We have a lot of higher number of patients in this age, group. And the fastest growing part of the cystic fibrosis population is the over 50, 60, and 70. You can see that here, we're talking about very few, patients. And now we have even, a significant, number of patients that are over 70. Why am I saying all this? Well, cancer happens in older adults, irrespective of whether they have CF or not. This trend also is expected to continue. So I think if we have another 10 years of this slide, we're going to see, an even, bigger distribution of this kind. And to emphasize this point a little further, the age where, patients die has changed. You can see that about the 50% of patients that passed away, unfortunately, 30 years ago, they were, in their early 20s. And right now, this age has gone to their late 20s and around 30 years. And at the same time, the mortality rate has been going down over the years. And this is before Trikafta. I expect this to go even, lower. So what does that mean? Effectively, it means we're going to have a lot more adult patients and older adult patients in our, population. And therefore, diseases that used to not exist in cystic fibrosis will exist now. One example of that is, for example, diabetes. If you look at reports from the 1970s, what they say is, oh, the endocrine pancreas is not affected. Diabetes is not an issue in CF. And we all know now that probably that's the most significant emerging, disease beyond the lung and the pancreatic insufficiency that we have in adults with CF. So this is just of things to occur, and we'll find out what, happens over the years. So this is an outline of why, cancer might become an important disease that we need to deal with in cystic fibrosis in the future. So the next, part, I'm going to go over the prevalence of cancer in cystic fibrosis before and after lung transplant. So the first reports of looking at cancer, I'm not going to, go over them in detail here. They were back from the 1980s when there started, being some case series of patients that were having GI cancers at a very young age. Over time, and as the registry collected more information or had more adult patients, there were some registry studies that were led, and they happened a couple of times from Patrick Maisonneuve. The last one is in 2013, and he tried to find out what the cancer prevalence of CF in cancer prevalence is in patients with CF using the US Cystic Fibrosis Registry. There are some issues with this because it's a moving target because the population is aging, and there's no mandatory reporting in the registry. So the incidence and prevalence might be underestimated. Having said that, cancer is a significant diagnosis, so I suspect that most of them are reported. And he divided his population into transplant patients and non-transplant patients. So looking at the non-transplant patients and looking at not skin cancer, because they didn't have reported the skin cancer the way that he was doing it, he found out that over 2 eras, the standardized incidence ratio compared to the general population based on age, gender, and all the other factors was basically not statistically different. You can see that the odds ratio here is 1.1 and 1.1 here, and when he combined them, they were expecting 154 cancers in the population. They found 172. So this is basically more or less, basically the same like expected from the population. However, when they went a little further into specific, cancers, what he found out, there were some that had different incidences compared to the general population of that age group. So I'm going to focus here just top line, things. GI cancers, they were more common, 6.7 times more common than expected. Testicular cancer, slightly above, the norm, and lymphoid leukemia, slightly above the norm too. On the other hand, there was, less, cancer of melanoma, basically. There was a little less melanoma. And then down here, they tried to find risk factors, and they found out, for example, that older patients have more, GI cancers compared to young, ones. And if you have a severe genotype, you're more likely to have some of those things. Down here is difficult, to make any sense of the numbers because they're so small. We're going to get to that a little bit, later, in the presentation. He also looked at transplant patients. In this case, there's even more limitations on reported because some of the transplant patients are not reported in the CF registry because occasionally the transplant centers are not located with CF centers, so there's a little more loss to follow up. However, what he did find, it was the definite increase in the risk of cancer after lung transplantation. So if you took out all but non-melanoma skin, very easily he found out that there was a higher incidence, of cancer. That was through both eras, and if you combine them, it was a definite, increase of 2.7 for all cancers. And to give you an idea, they were expecting 10 cancers and they got 26 out of this. To take this a little further, Eliza Fink did a study where she took the US transplant registry and then used, I think from about 10 states, state-specific cancer registries where they have everything reported, all the cancers reported, and try and combine them and find out where, and try and find out, because they have a lot more cancer information in those registries, and find out what the incidence is and compare them to non-CF transplant recipients and to the general population. So the general population is 1. The gray, circles are the non-CF transplant recipients, and the black ones are the CF ones. So they did this for a lot of cancers. And what they found out that there was an increase in the incidence of cancers, and it was 9.9 times the general population, while the non-CF were 2.7 times. And then if you look at specific ones, esophagus, colorectal, lymphoma came up. Those are some of the cancers that came up. This doesn't look very big in this scale, and that's because this is a log scale. So if you go, here, that's 10 times. So that's why, you don't see, a big spread or an increase, but it's a big increase from going from 1 to 10. So this is, just the background showing that there is actually an increase in cancer prevalent cystic fibrosis, which is magnified, especially after lung transplant. I already told you that it seems that GI cancers are the main, reason why we have, this problem. So I'm going to go and delve a little, deeper into certain, studies that we have, and going back to that Maisonneuve study and looking, specifically at colon cancer. Why colon cancer? Well, colon cancer is the most prevalent of all the digestive organ system, cancers, and it's the one that we also have a screening, modality. So when they looked back into the 1990 to 2009 digestive cancers, they found that they had 45 observed compared to 12.8 for an incidence ratio, odds ratio, which was 3.5. And most of those are colon cancers. And if they look at the colon cancers, it was 6.2. For the rest of the organs, there was also a similar increase. Some of them was higher than others, for example, the small intestine and the gallbladder. And the one organ that didn't seem to have, very much higher, numbers, as we can see, is liver and rectum. The other thing, to caution you about all this is that because the numbers are so small, one cancer, one way or another, could sway, things differently. So we are a lot more confident in the fact that, colon cancer is increased We do think that all the other cancers, most of them are increased in most organs, maybe not in the liver and the rectum, but at the same time, it's a little more difficult to prove because, you know, the confidence that we have on those numbers is a little, you know, less significant. So they came up, you know, that patients with CF, if they don't have, you know, a transplant, they have a 7-time increase of, you know, basically odds ratio 7 times higher than the general population for the same age of having no cancer. So then he went, you know, to lung transplant to try and find out what the risk is there. And there things are pretty obvious. For example, in that population that they were expecting 1 cancer, they got 19 of them for GI. So it was 17 times higher. And when they looked at colon, they were expecting, you know, 0.4 cancers in that population, they got 11, which is, you know, an incidence increase, you know, of 30 times. So that's a much, much higher, you know, risk of having, you know, a colon cancer after you have, you know, a lung transplant. And this was done also by the study by Think that we discussed, you know, before. So Think got, you know, some of the US transplant registry and you know, state-specific, you know, registries, and you can see for the colorectum, they found pretty much a similar odds ratio, 24. 30 and 24 is a little different, but not that much. It's the same order of magnitude. And again, you can see that rectum is the only one that didn't have statistical significance, but colon, proximal colon, distant colon, they were all significant. So this gave more credence to the fact that this is a real thing and a significant, you know, increase in the risk of cancer. Take this one step further. There's a recent meta-analysis that used data from a lot of the same, you know, studies, but from some other, you know, studies too. This is not an easy one to see, but what I'm going to focus on is the last diamond here on every, you know, aspect. So you can see small bowel cancer, there's an increased risk. Colon cancer, there's increased risk. Biliary tract cancer, there's increased risk. Pancreatic cancer, a little more difficult to discern because, you know, the numbers are smaller, but also there seems to be an increased risk. So there is no question that there is an increased risk of cancer. In this group here, we have, you know, transplant, you know, numbers. So if you look at the transplant numbers, they tend to be further, you know, far to the right, which means they have a higher increased risk compared, you know, to compared to the non-transplant population. In some, you know, studies, they didn't separate them out, so it was difficult to tell. So this is, you know, something that we need to deal with and reckon with. So we talked about cancer, but how, you know, does that cancer form, especially, you know, in the colon, which is the most common, you know, one. So there have been a few studies to look, you know, at colonoscopies and whether they find more polyps in patients with CF. So the first one was the study from Australia that looked at 50 patients with CF and matched them to 100 controls for age, gender, and colonoscopy indication. That meant, you know, that if they got it for constipation, both the controls and the cases got it for constipation. If they got it for bleeding, they got it for bleeding. And they found polyps in 6, you know, patients out of 50 CF patients versus 1 over 100 of control. So they calculated, you know, a risk of having a polyp 12 times higher. And then as far as, you know, basically, I'm sorry, that's cancer, I said. For polyps, it was 3.5. But so in general, they found an increased risk of having a polyp and an increased risk of having, you know, colon, you know, cancer. And you can see also the distribution, you know, of the polyps. And in the controls, most people had 1 polyp, maybe 2, 3, and 4. In the CF patients, most of them again had 1 polyp, but at the same time, you had a few people that went as far as having 4 and 7, which is, you know, a much higher risk factor of having a problem. The best study in my book has been reported from polyp formation from the University of Minnesota. University of Minnesota has done an excellent job in treating, you know, their patients. So they have the highest population of adult CF patients in the United States. So they started, you know, when they saw that there was increased risk of cancer, they started, you know, screening their patients over the age of 40. And by using that protocol, they found out that 50% had polyps, 25% had advanced adenomas, and 3% had colon cancer. And they tried to do, you know, the numbers are small because there's not enough, you know, patients, as you can say. But what they found out that if you are if you have delta F homozygote, if you have diabetes, you have a higher risk of having polyps. And then if you look at people that have the high risk polyp formation, they were more likely to be male and more likely to have a lung transplant. So all those are risk factors of, you know, the male sex, for example, diabetes are risk factors potentially of having, you know, basically more polyps. And having severe CF or a lung transplant, immunosuppression are also risk factors for maybe, making you at higher risk of having those problems. Finally, this study was replicated again at the University of Ottawa, which did basically a protocol of doing colonoscopies on patients, with CF, and then when the master controls, again, they found the same thing. So it was confirmed again. And why is this happening? So there's multiple reasons. Of course, we think that cystic fibrosis with pancreatic insufficiency leads to decreased, transit of basically food and stool, through the intestine and the colon. Maybe you have undigested food, you have, inspissated and thick secretions that stay there. So there could be a lot of reasons. However, one of the intriguing things is that maybe CFTR is an oncogene. So there's a study that looked at both a patient population and CFTR knockout mice. And after, they induced, some colonic tumors, they found out that the CFTR knockout mice had, much higher, rate compared to the controlled mice. And then when they looked in the same study, a true patient population of two different, types of sets, they found out that patients that had high CFTR expression, they had much better disease-free survival compared to the tumors that had low CFTR expression. And when they did some kind of multivariate analysis in this set, they found CFTR expression was the biggest predictor of progression. And CFTR expression also has been in another study found to be associated with prognosis in many tumors. And it's different effects in different tumors, so it's not certain, but in GI cancers, low expression is bad. So the CF Foundation convinced a group of experts, pulmonologists, a lot of GI experts as expected, patients, nurses, social workers, a lot of groups of people, parents, to try and come up with guidelines about how to screen patients so that potentially we prevent cancers that are preventable, because colonoscopy can prevent and remove cancers when they're early. And this is in a nutshell the recommendations that came out of this. I'm going to go over them very quickly. If you have not had a transplant and you are older than 40, then you should have colonoscopy, assuming that basically this is something that could potentially benefit you, meaning if you're not very sick, if you're not somebody that can basically benefit from screening. If we remove a cancer now, can we prevent cancer 10 years later? That's one of the questions that comes up. So if you have a negative one, every 5 years you should get a new one. And if you have a positive one, you probably should get surveillance, a repeat one in 3 years or earlier, depending on what the findings are. If you're a transplant patient, because this is so much higher risk, then we recommend at the age of 30, after you have recovered from transplant, which usually we say within 2 years, making sure that the transplant has worked and we're expecting the good benefits that come from that. These are the models that came into this, and I don't want to delve in those too much. The only thing I'm going to say is that based on certain modeling characteristics, immunochemical testing, Cologuard that you see basically advertised on TV, might be able to do the same thing, but it has to be studied in CF to know that the operating characteristics of the test are appropriate, because it might be, to put it plainly, this might be almost a useless test in the CF population. We do not know that yet. If it is anywhere close to the general population, it might provide a way of avoiding colonoscopies. Something about colonoscopies. This is the Minnesota PrEP for cystic fibrosis patients, and has been adopted in a lot of places in the US and elsewhere. The bottom line is you need a much bigger amount of cathartic to drink, like Golightly or Miralax or something like that, which makes it more difficult. That's why it would be good to avoid colonoscopy if we could. And an Australian group tried to find out the general PrEP versus the modified PrEP, and they found that the general PrEP, the standard PrEP, was much worse in visualization, had better good visualization, worse good visualization, and much higher rate of bad basically PrEP, and they were not as able to find basically adenomas. So this works, and we've seen it also in our own experience. So that's one of the things that makes it if you're going to do the colonoscopy, you might as well try your best to have a good one, so you don't have to repeat it. I'm going to go out of GI cancers now and go to the skin cancers, and we're going to focus mostly post-transplant here. So here is a survival of lung transplant recipients, and this is cancer-free survival. So cancer is pretty common, and you can see that about half the patients are going to have some form of cancer by 12 years basically. The most common one is skin. You can see that skin is basically present about 50% of patients by year 15. That's the green line. And malignancy is an important cause of death as we go further out. So it accounts for people that start going, beyond the year 3. It's more than 10% of deaths are from malignancy. So that's significant, issue. So how about, skin cancer? What do we know about it? The study by Maisonneuve tried to look at melanoma. That's the only one that I had, basically access to. And it showed that there was actually, if anything, a decreased rate of melanoma in patients with CF. We don't know why. It could be, maybe because the CFTR has a protective effect. It could be maybe that we have decreased exposure, to the sun. It could be that there's increased immune surveillance. Basically, the immune system is activated and fights, basically melanoma. And melanoma is one of those immune-mediated cancers that gets, very affected by that. We do not know this answer, but you can see the answers there. And again, looking at melanoma in the FINK study, you can see that it is very similar to the non-CF population, to the general population. A study from Sweden tried to look at all skin cancers, not just melanoma. And what they found out is that patients with CF had an increased risk of non-melanoma skin cancer, but their relatives did not. And this and it was 7 times higher than that, risk in patients, with post-transplant, which is not, basically unexpected in some, perspectives. So this is obviously a Swedish population, which has different characteristics, so we don't know how that is. But in general, for the non-transplant population, we are not so certain what happens. However, looking, at the transplant population, this is a very well-known, and big-time, risk factor. And there's a lot of, cancers that occur, and it's more common in Caucasian population, in the older population, more common, in males. And there's squamous cell cancer, which is the majority, and fewer, melanomas, thank God, which are worse. So there is definitely, an increased risk of cancer in that population. What I'm going to go focus, and say a few words next is about a significant interaction with a medication class, and mainly one medication, voriconazole, which we use pre-transplant and a lot post-transplant as treatment and prophylaxis for fungal medications. So this is, the report of a large multinational, multi-center trial of 900 transplant recipients. And what it shows is that if you use, voriconazole, you have a much higher risk compared to the unexposed population for having, skin cancer. And other azoles, other, posaconazole or itraconazole might not have the same risk. So that's significant. Going to the next slide, we find out that if you have anything above 90 days, then you have an increased, risk compared to before. So this is something to keep, in mind, especially if you're going to use voriconazole on patients, post-transplant, for how long. Finally, I'm going to go, next, to lymphoma, which is another post-transplant, mainly diagnosis that we have to deal with. Same slide like I showed you before. This time around, you're going to see lymphoma as the purple line, which is less common, but still it becomes, a significant risk over, a period of years. And it's not a high, number cause of deaths, but it's a small but significant. A few percentage, of patients die from lymphoma after lung transplant. And you can see, in the FINK study, that basically lymphoma is one of those things that is increased in the CF population. So they found out that in the non-CF compared to the standard population is 2.7 times, and then for CF is 9.9 times. So it's definitely, higher for CF. Another well-done study by Erin Lohr at Loyola used the UNOS, registry to find out what the risk of patients with CF is, and found out that after adjusting for everything, CF patients had about 1 2/3 the risk of non-CF population if they had the same, basically characteristics. And EBV mismatch, meaning you could get a donor that's positive, which most donors are, 95% are, given to an EBV negative patient, which in CF, it's much higher prevalence because probably the population is younger than otherwise. It might be, as high as 40%, while the general population is higher, is the main risk factor for having, basically this problem. And this is, different models. They use the non-CF and a CF. I'll focus on the CF. So having, a high risk EBV makes it much higher that you're going to get lymphoma. And age is protective. The older you are, the better you are off in this, disease. That's the one exception that we have, basically, from our perspective. And seeing it, in different ways, and the non-CF patients being an EBV mismatch makes it much more likely that you're going to get lymphoma. In CF, this risk is even magnified. So if you have an EBV mismatch, then you have a much higher chance of being, basically having, a lymphoma. Now, this is a long time frame. It's months over here. So we're talking about 10 years over here. So it might be, and the numbers are such that, this is 85%. It's not like, basically 50. So there's a big difference, but it's magnifying because of the way the graph is. So I don't want you to take, that I'm going to get lymphoma for sure if I have an EBV mismatch. Then we're looking, in patients that basically have in the U.S. transplant, the U.S. transplant registry and the specific countries registry from Liza Fink, and found something very, similar. If you look at the multivariable analysis about CF and what's the risk for lymphomas, you found the same almost number, 1.6, like Anne found, and found out that if you are, an EBV negative, which most likely you're a mismatch, you increase, your risk, and it's something that, it's more common in the younger population. How about, non-transplant, population? There, we don't have enough data. So there's some increased risk of lymphoid leukemia in patients with CF that we talked about in the first few slides, and you can see it over here. We do not know if this has anything to do with the increase in the PET-TLD risk, irrespective of the EBV mismatch status. The lymphoma itself is not increased, but the numbers are so small that it's difficult, to know what is true and what's not true from our perspective, and that's something that we're going to find out over the years in a little bit. So I'm going to finish by concluding here. So one of the things I'm going to say is cancer seems to occur more frequently in patients with CF, especially in the GI tract. Post-transplant, this creates further challenges and is definitely even more increased. We have a lot of unknowns, and we're finding those unknowns as the population ages. So if we're having, these numbers right now, in 10, 15, 20 years, when we have a much higher rate of older patients, we might be facing problems with cancer a lot more frequently. But there's a lot of hope. As you saw earlier, some of the those cancer risk might be more basically happen because of CFTR problems. So maybe the CFTR modifiers might fix some of the CR problem and create a risk modification that make this less likely to happen. But this is something that we need to obviously assess in the future and carefully follow.